nose, secretions in the airways, secretions in the GI tract, secretions in the skin, so diaphoresis. Okay. We see smooth muscle contraction. So where do you see smooth muscle? Well, in the eyes. That's why the eyes constrict. The picture that you see here, the top one, constricted pupils, that's actually a guy who was inadvertently exposed to nerve agent. Okay. Constricted pupils. As you follow the pictures down, you see the pupils gradually dilate. Okay. That time frame was 2 months. That's how long it took for the pupils to recover. Okay, 2 months. We have smooth muscle in the airways, bronchoconstriction, like asthma. Smooth muscle in the GI tract. They constrict, nausea, vomiting, diarrhea. Okay. Skeletal muscle, all our muscles, start twitching. Over time, they become weak, and eventually they'll become paralyzed. Okay. When we have overload of the central nervous system, we see tachycardia, we see hypertension, we see a whole variety of cardiac dysrhythmias, heart blocks potentially, and if it affects the brain, seizures, loss of consciousness, respiratory arrest, ultimately death. Okay. And then if you do survive, lots of these folks have profound psychological effects that last 4 to 6 weeks. Okay. So how will we recognize this is going on? Recognize the symptoms. Okay. What you're looking for is a whole bunch of people complaining of exactly the same thing at exactly the same time, all in the same location, because they all got exposed to the chemical. Okay. So vapor exposure, gas exposure. Okay. Mild exposure, really not too bad. You know, you get the constricted pupils, you get a runny nose, get some shortness of breath. As the exposure gets worse, the symptoms get worse. Your shortness of breath gets worse. You start seeing nausea, vomiting, and diarrhea. Then progresses to loss of consciousness, seizures, respiratory arrest, paralysis, and death. Inhale the vapor, your symptoms are going to start to present within seconds. Okay? There's no late onset. It happens within seconds. On the other hand, if you get exposed to a liquid, that can take time for it to develop symptoms. Mild exposure, up to 18 hours. This means you respond to somebody who has an exposure to a nerve agent. Okay. They look good, don't cut them loose. Okay. Transport them. They need to be watched for 18 hours. Mild exposure of a liquid to the skin, you're going to see localized sweating around the area where the exposure occurred. So get some on your arm, you're going to see sweating around that area. Okay. You're going to see localized muscle twitching around that area. And it tends not to affect the pupils. As the exposure gets worse, you start seeing more and more symptoms. You see the GI stuff, nausea, vomiting, diarrhea. Okay. And then if you got a big exposure, loss of consciousness, seizures, all that same bad stuff. Okay. How do you treat them? Well, number one is ensure they got a good airway. Okay. Their airway, if they have the bronchoconstriction, it's going to be like asthma. So you want to treat them. Okay. Suction them out. Lots of secretions. Suction them out. Intubate them if you have to. Bag them if you have to. And then the good news about nerve agents is we do have a treatment. We've got antidotes for them. Atropine, 2-PAM or pralidoxime, and Valium for the seizures. Atropine. Atropine specifically works at the muscarinic effects. Muscarinic effects, mostly the secretions and the smooth muscles. Okay? So you're giving atropine to dry up those secretions. You're giving atropine to relax the smooth muscles. You can give it IV, you can give it IM, you can give it endotracheally. It does not affect the muscle twitching or the weakness. Okay? If you give it IV in a patient who's hypoxic, you might precipitate ventricular fibrillation, so be sure they're oxygenated, okay, before you give it. How much do you give? Well, you start with 2 milligrams. Okay. What do you use in your average run-of-the-mill cardiac arrest patient if they're bradycardic? 1, half to 1, right? Okay. We're going to start with 2. And we're going to keep giving atropine every 5 to 10 minutes until the secretions are dry. Until, if you're bagging the patient, until it's easy to bag the patient. That may take 10, 15, 20 milligrams of atropine. How much do you carry? 6 max? Okay. So bottom line here is, if you had a good nerve agent incident with lots of victims, okay, you ain't got anywhere near enough atropine that you might need. Okay. Atropine does have some side effects. Who the hell cares? Okay. This is a nerve agent poisoning, so we're going to use the atropine regardless of side effects. Now, we're talking nerve agent. If this was an insecticide poisoning, okay, farmer sprayed his crops, got exposed. Insecticides frequently take even more atropine than the nerve agents. Okay, so 20, 30 milligrams might not be unusual for an insecticide poisoning. Okay.
I talked to the group this morning, let them know that we are trying to get the Mark 1 kids back on the rigs. If we can't do that, then we're going to at least put them on the BC vehicle with the cyano kit. So there'll be like a dozen of those there, so you can start with your atropine and then call in the BC. And Dr. Pons will go over the Mark 1 kids if you guys aren't familiar with them.
So atropine, as I said, how much do you give? Till the patient's dry. Okay. Turn them into a prune. Make them dry. Okay. Also, if you had intubated that patient and you were bagging him, you're going to give atropine till the bagging is easy. That tells you that you relaxed the smooth muscles in the lungs. Okay. That you've relieved that respiratory problem. Okay. 2-PAM. 2-PAM works at the nicotinic sites, not the muscarinic sites. This is why we have to use both medications in these patients. Okay? What 2-PAM does is it breaks apart that bond between the nerve agent and the acetylcholinesterase. It reactivates the acetylcholinesterase so that it can once again get rid of acetylcholine. Okay? Now, that's great. The problem is, over time, that bond between the nerve agent and the acetylcholinesterase becomes permanent. So we got to get the pralidoxime in before that happens. Okay? You see the dose there. You know, I'm not going to ask you to remember it because we all will look it up no matter what. So here's what happens when it becomes non-permanent. If you get it in quickly, you break that bond, you reactivate the acetylcholinesterase. If that bond becomes permanent, then you can give all the pralidoxime you want. It's not going to help the patient. Okay? We call this aging of the bond. How much time do you have? Depends on the chemical agent used. If this terrorist was smart enough to use soman, you have 2 minutes after exposure to get the 2-PAM in. So the reality is that ain't going to happen. Okay? If it's sarin, which is perhaps the most commonly available agent, you've got about 4 to 5 hours before that bond becomes permanent. Not unreasonable. If it's VX, we have 2.5 days to get it in. Okay? Now, you respond to a nerve agent poisoning. You get there, the patient's got signs and symptoms. How do you know if your 2-PAM is going to work? How do you know if the terrorists use soman, sarin, or VX? You don't. You have no idea, so you use it anyway. If it was sarin or VX, you're going to benefit the patient. If it was soman, you know, the 2-PAM is not going to work. You're just going to use the atropine. Okay? Benzodiazepines. The slide talks about Valium. You can use the benzodiazepine du jour, okay, whatever it happens to be this week. Okay. The benzo's obviously good for the seizure activity. And they recommend that if you have someone who shows signs of severe nerve agent intoxication, so the patient who has nausea, vomiting, diarrhea, shortness of breath, trouble breathing, all that good stuff, okay, give them the diazepam even before they seize. Okay. There's our Mark 1 kit. Okay. How many of you have played with the Mark 1 kits? A couple of you, okay. Auto injectors. The small one there is the atropine. It's 2 milligrams in there. Okay. The big one is the pralidoxime. That's 600 milligrams. They're numbered 1 and 2. That's the order you should give them in. Okay. Now, as the Mark I kits are expiring, they are combining the atropine and the 2-BAM into a single auto injector called Duodote. Okay. The nice thing about this, well, 2 nice things about this. One is you're only injecting the patient once with the auto injector. And 2 is the Duodote costs more than the Mark I kit, so the manufacturer makes more. Okay.
They know it's going to require more atropine. Why don't they make those with more milligrams?
Because if it's I'll show, hold that question for 1 second because I have the answer for it. Excuse me. Depending on where you get your Duodote or Mark I kit, okay, the military version is labeled slightly different. The Duodote is labeled antidote treatment for nerve agent auto injector, ATNA, okay. It's the same thing, so you may see this instead of the labeled Duodote. It's the same stuff, okay. Valium, if you get military auto injectors that are Valium, okay, they're not going to say Valium or diazepam on them. They're going to say Cana, C-A-N-A, convulsion antidote for nerve agent. Okay. Why'd they do that? So it's not abused. They didn't want the soldiers to know they were carrying Valium. Okay.